Welcome to RSSDI TV 2020. I am Dr. Sanjay Kamble, and on behalf of Wockhardt RSSDI 2020, I welcome you all. I am glad to have with us today a renowned endocrinologist from Ahmedabad, Dr. Navneet Shah. Dr. Shah is one of the foremost figure in the medical field of Gujarat. He is the honorary physician, diabetologist, and endocrinologist to His Excellency, the Governor of Gujarat. Besides, Sir is the director at Department of Diabetes and Endocrinology at Sterling Hospital. Welcome, Dr. Navneet Shah, to the show. So, sir, based on your current recent talk in RSSDI 2020, we would like to know which is the most common cause of glycemic variability.
The commonest cause of glycemic variability is probably the mismatch between the diet and the medicines which the patient is taking. And that leads to a kind of thing which really produces mismatch leading to glycemic variability. And that is why when we look at the patient's profile, we have to look at his diet profile, his activities, the kind of diet he takes, and then his medicines, because we know there are medicines which would work for both fasting and postprandial sugar working for 24 hours. There are some medicines which are insulin independent medicine, and then there are some medicines which are secretagogue. And then in the recent armamentarium, we have short acting analogs which really takes care of the prandial hyperglycemia. Likewise, the prandial hyperglycemia is taken care of with DPP-4 inhibitors, GLP-1 receptor agonists, and alpha glucosidase inhibitor with acarbose and voglibose like drugs, which really helps in reducing the postprandial excursion of blood sugars. So I think glycemic variability is a lot of factors. Then there are intrinsic factors which would depend upon the hepatic glucose output and hyperglucogonemia and other things also, which are a part of intrinsic pathophysiological mechanism of type 2 diabetes. So that is the reason when we plan a treatment for glycemic variability, we look at many factors, including the glycemic control, the fasting, postprandial blood sugar. Then we look at the A1C target, which is the gold standard up to now. And now we have in the recent development of time in range with the advancement of CGMS, various types of CGMS, which are Medtronics and Abbott systems are available. So we have improved our knowledge regarding the glycemic variability and types of food related to that. And then even during the night times also the glycemic variability is now obvious. And then we don't have to have frequent pricking of the fingers for looking at the blood sugar, and that really helps in knowing the glycemic variability.
Thank you, sir. So, what are the immediate and long-term consequences of glycemic variability?
The first thing which I would really focus because of the increased glycemic variability is then that is the highs and lows. If you have a very significant lows, you know the complications of hypoglycemia like cardiovascular events, stroke, fall, and host of the things which can even be fatal sometimes. So hypoglycemia is on the one spectrum of glycemic variability, and the other spectrum is hyperglycemia, which has also problems with the control of diabetes and then related to the over control, the uh, proneness to infection, poor wound healing, and all those things are responsible. But the most important thing is that the high glycemic variability leads to endothelial dysfunction. And we know that there are increased possibilities of endothelial dysfunction and macrovascular events because of the high glycemic variability.
Thank you, sir. So, how do you overcome the glycemic variability?
I think we are having now new drugs. First, the knowledge of glycemic variability is very important. If you do not know what is glycemic variability and what is the pattern of glycemic variability in the patient, you will never be able to know what you should do. So once you know that, then our focus would be how to reduce the glycemic excursions from lows and highs. So if you are dealing with predominantly a hyperglycemia and which are you have to find out whether they are fasting hyperglycemia or they are postprandial hyperglycemia, and you have to act or you have to fine tune the medicines according to the problems. If you have hypoglycemia, then you have to find out whether this hypoglycemia is because of the secretagogues and whether it is coupled with hypoglycemic unawareness or not. So once you define the problem, then and then you can do best for dealing with the glycemic variability. Like we have some good drugs which will really take care of the prandial hyperglycemias. They are short-acting analogs, and now we have very ultra-short-acting analogs also available. We have a better basal insulins that also produces some help in fine-tuning that. Then we have GLP-1 receptor agonist, which increases the first phase insulin response and produces better postprandial hyperglycemic control. And then we have drugs like acarbose and the voglibose, which will really take care of the prandial glycemic exertion. So hyperglycemia, which is essentially a prandial hyperglycemia, can be taken off with these three drugs. Now, once you know there is a hypoglycemia and there is hypoglycemic unawareness, then you can always find out, improve the control, like you have to downgrade the control first because there is a good glycemic control for a prolonged period of time is invariably associated with hypoglycemic unawareness. Whether patient is having autonomic disturbances or not, that is also you have to find out. And after knowing that, what is the reason for hypoglycemia, whether it is a nocturnal hypoglycemia, whether it is a whole daytime hypoglycemia, and then out of that you have to find out what is the culprit for hypoglycemia, whether it is secretagogues, sulfonylureas, metaclinides, or insulin, or overall you need to improve upon the strategy. If patients are having the drugs like which potentiate the effects of the other drugs, then where can you change the things? So I think these strategies would depend upon defining the problem and really evaluating the patient status regarding the various associated morbidities like hypoglycemic unawareness, polypharmacy, age of the patient, and so many things. Like even sometimes the variabilities also should be seen in the light of chronic kidney disease or chronic liver disease also, and then you can find out how to make the changes comprehensively in this kind of patient. So I think these are the various things which I would keep it in mind when I deal with the glycemic variabilities. And then along with that, the other drugs for the other comorbid condition also we have to see, because there are some drugs, they potentiate the effect of hyperglycemia, like calcineurin drugs or the atypical antipsychotics or the steroids. And then there are drugs which really can potentiate the effects of hypoglycemia. So all these things we should keep in mind when we are planning for fine-tuning the management of type 2 diabetes, where our focus is good glycemic control, time in range, along with prevention of weight gain, prevention of hypoglycemia, and reducing the glycemic variability. If we focus, and then of course, reducing the cardiovascular outcomes and improving the renal outcomes also would be two important facets of the modern management of diabetes.
Thank you, sir, for sharing your views, and stay tuned to RSSDI TV 2020 for more recent updates from RSSDI 2020. Thank you very much.
Thank you, Sanjay. Thank you.